Hi everyone, this is Anya back with the Thinking Mind podcast, and this week I'm really excited to speak with Professor Brendon Stubbs. Professor Brendon Stubbs is a clinical academic physiotherapist with an interest in physical activity and mental health and the mind-body interface. He's conducted heaps of research to demonstrate something that perhaps some people would say we instinctively know, but that medical care has struggled to include, which is that moving so often makes us feel better. I hope today that we can talk about the ways in which this happens, what the evidence shows, and what some of the issues might be in translating this into clinical practice and what we might be able to do. This is the Thinking Mind podcast. Here you can access in-depth conversations all about psychology, psychiatry, psychotherapy, and self-development. Hope you enjoy. Professor Brendon Stubbs, thank you for joining us today.
Thank you so much for having me. I'm really pleased to be here.
So, Brendon, you do fantastic research and fantastic clinical work that looks at the mind-body interface and how we can improve our mental health with movement, but also the interaction between both our physical health and our mental health. So I hope that we can talk about that, exactly that interplay, but also the interplay that you have between your research and your clinical work, and your thoughts about how we can translate things better, and also any practical advice that you might have for clinicians on the ground for what they can do with the limited time that they often have with people, sometimes potentially the limited expertise. But if there are any thoughts on what you have on simple things that we can do.
Absolutely.
I'm keen to just go right into it from the beginning. And I guess I wonder if I could ask, at the moment, what kind of problems or what kind of questions is your research trying to explore?
Yeah, so there's a few questions that we're doing at the moment. I think the big question that I'm personally really keen to do is really around the translation, because over the past sort of 10, 15 years, we've done a great body of work to really sort of shift the field, a huge global collective. So I'm just speaking globally, not about my research per se, to sort of evidence that sort of physical activity and movement could play an important role in health promotion for mental health, physical health, we know, and then also as an adjunct for treatment. I'm sure we'll go into that. And also there's been a huge shift in terms of the care of people's physical health that have severe and enduring mental illness. So I think we don't really have a knowledge issue now. So really the focus of a lot of the things I'm doing is how can we translate that? What can we do in sort of practice? What tips can we do for people, rather than sort of niche research questions? All of that is important. And if we did say sort of what my niche research questions beyond that, or my research questions, so a few main areas at the moment. So we're looking at the relationship between chronic pain and mental illness, and the sort of bidirectional relationship, and what happens when people with mental illness have pain. How is their treatment different? How are their outcomes different? And also developing an intervention for that group, because we've done a systematic review showing that, unsurprisingly, people with diagnosed mental illness are excluded from virtually almost all chronic pain intervention programs. So there's huge gaps for our cohort. So a big body of work around pain and mental illness. Then we're also looking at some physical activity and exercise interventions. We've got 2 trials running at the moment. One is with people with subjective memory complaints, dwelling in the community, and seeing if we can do an aerobic and strength training program to stimulate hippocampal neurogenesis, and looking at gut microbiome changes as a possible factor that influences the neurogenesis process as people age. And the other trial that we're working on is a 400 person RCT across multiple trusts in England, where we're looking to help people with severe mental illness to become less isolated and more physically active within their community. So we've just finished a feasibility study, and we're looking to do the full trial, start that later next year. So those are the sort of core focuses of the work that we're doing at the moment. So quite applied questions, really, that patients often tell me are important, but I may see a biased sample as a physiotherapist.
And I guess you made reference to the fact that the knowledge base really is there now, that over the last 10, 15 years, the community has generated a huge amount of evidence. And I know I've heard you talk about how impressive some of that data is. And I wondered, just to give everyone a sense of where things are at, and we won't dwell on it, as you say, because it's that bit is there and is there for people to listen to. I can point them to some of your other podcasts if they want to hear more. But just to give them a sense of where this has come from, particularly in things like perhaps not just severe mental illness, starting from depression, but also where things are at as the base for the work in severe mental illness as well.
Yeah, so I think that when I first started working in mental health services and was starting to become interested in the literature, sort of physical activity, exercise and movement and physiotherapy was really undefined and was quite wishy-washy. And it was quite flaky in terms of the evidence. And quite rightly, many people thought, I'm not really sure if this is good. In principle, it sounds great, but what is the evidence base? So that was kind of like the starting point. But my own clinical observations were people were finding it helpful. So I think really sort of fast forwarding on to where we are now, so we've got a big body of data looking at prospective cohort studies, so people who are free from depression at baseline and following them up to the incidence of depressive symptoms or a clinical depression. And we've shown that, when we adjust for other things as best as we can in observational data, that people who are more active at baseline are around 15% less likely to develop depression in the future. And that relationship was evident in young people, adults and older adults, and across both genders and all geographical continents. We all know that depression is heterogeneous and a complex condition, but this is just going to show that it could be an important factor within that. So there's good observational data. And the data also shows that people who engage in what is known as like the recommended targets of 150 minutes per week continue to see a benefit for protection against poor mental health in the future, for around 30% for people meeting 150 minutes per week. So that's kind of like the observational data. So we can see a direction in the relationship. And there's a big paper in American Journal of Psychiatry we published in 2019 looking at that. We've also looked at fitness as well. And by I mean fitness, we've got a couple of measures that we look at. So how well your heart and lungs respond to an exercise stress test. And we've shown a similar thing in big data of people free from depression at baseline, and people who've got sort of better cardiorespiratory fitness are less likely to develop depression in the future. And we've also looked at the other sort of main fitness system, which is muscular fitness, and shown that people who have stronger muscles are less likely to develop new cases of depression in the future. So it's not only important around what we think is about how much you move, so physical activity, but also having heart and lung strength and how that responds to a stress built on the system, and having strong muscles. And I think what adds strength to this observational data is that there's been a number of Mendelian randomization studies, which take, I'm not an expert in the methodology, but have been co-authoring papers, where it's sort of taking further the observational data and looking at causal pathways through sort of genetic mediated analysis. And we did a paper earlier this year in molecular psychiatry looking at objective physical activity and the incidence of various mental disorders in the future. And again, sort of reaffirm the relationship that there does appear to be a causal pathway between physical activity and depression. So we've got the observational data, we've got some Mendelian randomization data saying, this is probably important. And then also when we look at people who do have, say, depression, the evidence base as a treatment has also improved. So there was a really bad Cochrane review published in 2013, which has not been repeated. And there's a really good piece on that, which is sort of like a critique of it, called Anya, the pooled standardized mean difference. And it's just going through all of the methodological issues that were within that. So we updated that, and several other people have too, to show that when you compare exercise as an add-on treatment for people with depression compared to usual care, you get significant and clinically meaningful improvements in depressive symptoms. And this is evident whether you look at aerobic training or resistance training. And then just to sort of bring up to date where we are with the evidence now, because the evidence is not perfect. Of course it's not. It's difficult to do behavioural research compared to a placebo drug, for instance, although we're often held to similar standards. But there's two trials that I would like to sort of highlight to show how good the evidence could be. And this is not to compare it to other treatments, but it's just to say it could have a place at the table as part of a menu of options. So there was a trial done in the British Journal of Psychiatry by a colleague, Matt Hallgren, in 2019, the Regassa study. And Matt's addressed sort of two key issues within the limitations of exercise and depression literature. The first is that many of them were short-term follow-up. So many were sort of like up to 6 months, for instance. And Matt's did a 12-month randomized control trial. And also, it's hard to get funding for exercise research compared to other industry-funded areas. And so often the studies are smaller, and Matt's did a very large, almost 1,000 people, 3-armed randomized control trial. People with depression dwelling in the community. One group were randomized to usual care. The other group were randomized to ICBT, which we know is an important treatment for people. And then the other group had exercise delivered in the community. And so over 300 people in each arm. And what Matt showed in this study is that after 12 months, both exercise and ICBT were similar in terms of the improvements in depressive symptoms. And there was no significant or clinically meaningful difference, but both, as you would expect, were better than usual care. So this is trying to bring some sort of equivalence in terms of how this could help. And I've not really spoke about the other physical health burden that people with depression may experience and how exercise could help with that. And this is slightly addressed by another really nice randomized control trial, which is not perfect at all, but it's a novel and interesting concept. It was done by Brenda Pennings and colleagues in the Netherlands. And what they did was a specific type of exercise, a randomized control trial. People in the community were randomized to have antidepressant medication or have running therapy 3 times a week, guided running therapy for a 4-month intervention. There was some sort of slight nuance around the randomization, wasn't perfect, but the concept is there. So I'm not saying this is a perfect trial, it's not, but it's just to sort of show an indication of how helpful this could be. And what they found is that exercise or the running therapy and the antidepressant medication were both as effective as each other in improving mental health symptoms. But as you would expect, there was less physical health problems, cardiometabolic issues in the running therapy group compared to the antidepressant medication group. But, a caveat to that is that, unsurprisingly, people saw more dropout in the running therapy group. And there's a number of reasons, I suspect, for that. That's probably a rather long introduction to the topic. I don't know if you want to divulge into any of that.
No, that was a fantastic introduction. Thank you. I'd love to dive in. And again, I guess I'm curious about some of the limitations that you point out and some of the maybe reasons also for why translation can be challenging. I guess I understand from some of your work, particularly some of your meta-analytic work, that one of the limitation overall of the field can be that people who are selected for the studies might be chosen depending on their willingness to engage or their sort of readiness to engage with physical activity. And I wonder how that links to the higher rates of dropout in the trial that you mentioned as well, and just how you think about that and what you make of that.
Well, I think first and foremost, I've been involved in placebo trials where there is a pharmacological agent and there is a placebo, and there are caveats to that, but it's far easier than doing a behavioural intervention. It's really very difficult, if not impossible, to sort of blind a person receiving exercise, yes or no, and it's obviously blind for the people delivering the intervention. So there's a number of issues which make it more difficult. And what we tend to see in the physical activity and exercise literature, and I've seen this in trials I've recruited and been involved in myself, is you tend to invite someone to be part of a study and say, "Come, would you like to take part in this randomized study of physical activity? And these are the potential benefits if you take part." And but you have a 50% chance of being in the movement group or the control group. And you talk to people about this, and they're like, "Great, it's great." And then you randomize, and they're in the control group. "Oh, I really want to go and start moving exercise, and I'm going to go and do it anyway." And I've had that numerous times with people in trials I've recruited for. And what we tend to see in the literature is that people who are recruited to physical activity interventions in the control group tend to become more physically active. So there's meta-analysis showing that when you recruit into a control group, all of a sudden people's physical activity levels also increase. So there is a sort of conflation of the effect within that. So it's a complex area to sort of do research, but it's I think it's really worthwhile and noble. And I think that when it comes to the study in the Netherlands, which I mentioned, I think there's a number of reasons why they saw a higher dropout. Obviously, engaging in any exercise, but particularly running, it requires effort, requires motivation, and it's hard. If you're struggling with depression and many of the symptoms, then going out and doing an activity which is by nature meant to be challenging to your body, then people are going to find that more difficult. And I think the key thing that from translation I've taken from clinical work and also research is that we shouldn't be too prescriptive about the type of movement that we're getting people to do. So, I know many people that if I said we're going to do a running intervention, by nature, at least half of people think, I don't like running. Whereas the key message from translation is it's not, the type of movement is less important. It's about finding a movement that you enjoy. That could be Pilates, yoga, high intensity interval training, strength training. It could be running. It's more important to focus on the actual engagement in the behavior, the time that you do it, get some consistency, and then you can focus on intensity. So I think by nature of having a very specific exercise intervention could have also played a role. But I understand from the research perspective is you have to have these clearly defined protocols of what people are going to do. So it's caught in between the challenges between what may work in the real world and what we want to do in a trial.
The importance of trying to control things in a trial, but also the limitations that then come with that for the real world I can imagine, are a huge challenge. Where are things at with other types of mental illness? So, and I'm particularly curious about your work with psychiatric services, I guess, with inpatients, people living in the community as well, with things like perhaps bipolar, schizophrenia. I think schizophrenia in particular, we often talk about less than we do depression, just generally in the mental health world when it comes to public communication. So yeah, I wonder where are things at with that and with the big trial that you're running as well?
Yeah, sure. So, there's a really compelling rationale for including physical activity and exercise as part of the holistic care of people with schizophrenia. We know the heightened physical comorbidity. We've demonstrated very high levels of sedentary behavior and low levels of physical activity, much more so than depression or bipolar disorder. So we know that this is a risk factor. And if we look outside of this, we know within large trials that in the general population, physical activity and exercise is just as effective as some common pharmacological treatments for cardiovascular disease management and also related death. So the rationale is strong for physical health reasons and also for mental health and cognitive reasons. And the evidence base for schizophrenia is pretty good. So we have looked at the effect of exercise, aerobic exercise specifically in randomized controlled trials in people with schizophrenia and shown that it can improve numerous cognitive domains. Then we did a paper in the Schizophrenia Bulletin, I think it was 2019. Joseph Firth led that. So there's good evidence that you can improve multiple cognitive domains, which we know is a key feature for many people with schizophrenia. And there's also evidence that it can improve people's negative symptoms, depressive symptoms also. There's some evidence that it can improve people's physical health, but we know this is particularly hard for many people, particularly whilst on treatment. And what I will say is most of my clinical work has been in inpatients to a varying degree. And I think we've looked at this. We tried to do a trial, but it had to be a kind of like abandoned or modified during COVID-19 pandemic, where we're going to be doing a trial in inpatients. But what we do know is that there is good evidence in inpatients. We can see improvements in mental health symptoms, in engagement, in motivation. But the challenge always is that what happens when people leave. We set people up really well, We get people sort of comfortable, confident, motivated, experiencing some of the benefits for themselves, and then go out into an environment where they perhaps may not know where the local facility is that they would like to continue their movement. They may not be able to get there due to financial reasons or other reasons, or there may be other challenges. So really what I've observed, and I think is a gap within the evidence base and translation, is how do we translate what we can do in inpatients to people when they move into the community? I think that's a huge role which we've got to do going forwards.
And I guess when we're talking about the potential benefits and things like cognitive negative symptoms for people who may not be medical professionals, what we're talking about is, I guess, things like someone's ability to think and potentially solve problems. And negative symptoms include things like feeling unmotivated, feeling low, appearing quite withdrawn, appearing like your thinking processes may be a bit slow, or just like there's something getting in the way of you being able to think. Are those the kinds of things that you've worked with, or other things as well?
No, absolutely. I think those are some of the really key things that we've worked with. People's ability to sort of think clearly, feel sharper. People often report to me, I'm sort of able to sort of think more clearly. I feel like I'm getting my memory back. Those kind of things that people will report to me when they are responding well.
I guess I'd love to hear really just practically like how you do the work both in inpatient wards, and also how you're thinking about translating it into the community. Because from my clinical experience on wards, it is people are quite sedentary, and it's sometimes just the availability of what there is to do is limited, but sometimes even when there is availability, and this is, I think, both for people with schizophrenia, with emotional difficulties who are in hospital, just getting people to want to do it, getting them to agree, and even if they agree, I guess getting them out the door, we really struggle to help them get to that point. I wonder how you do it.
So not by any perfect means, but what I will typically do is often talk to people about the difference often people find quite helpful between exercise, which can be quite an emotive word for some people, particularly if you've had sort of negative experiences in PE or physical education at school. Many people say, well, it's not for me, I'm not an exerciser. And really what we're talking about is the benefits of movement. So it's talking about movement. It could be, physical activity by definition is any bodily movement that increases energy expenditure. So that could be for you dancing, it could be, Tai Chi, it could be walking, it could be structured exercise, going to the gym, doing a yoga, Pilates exercise. So it's really giving, sort of distilling some of the sort of the challenges that people immediately face. I often find that's quite helpful for people. And then just some more education with people, just sort of saying that you don't need to go for a half an hour run or do half an hour. Just getting up and just doing a few minutes of a movement that you choose to do and intensity that you want will be helpful. And in fact, what the research shows is that often people who are the least active and the most sedentary, they tend to see the greatest benefit in terms of their health outcomes initially in response to that. So just some sort of empowering conversations to start off with. And then, I'll often go and do some movement with the person, go for a walk, or just do something really simple. So just trying to make the bar as low as possible and trying to help that person move from this external motivation to having some internal, experience and introjected motivation where I feel like, yes, I can do this, and having a positive experience. And we all like to feel that we can do something. So it's really important to have that bar low, because what we don't want to do is, set something too high and feel like I've failed. So having that low bar and having a positive experience is really, really important for people. So I will often do that and do some sort of motivation around that. And then once people have started, just work on some consistency, and that's kind of what I'll do.
So the idea of helping them to see that it's starting low, starting with something that maybe even feels too small, but to give them that easy win, that feeling of it's the sort of accomplishment, and that then can kickstart more motivation that then helps to maybe get towards building consistency. I imagine the building of consistency is the next challenge.
Absolutely. So that first win, low bar, achievement early on is so key to get people thinking, yes, I can do this. Because if, many people talk to say, I can't do it. So, it's just a case of going in and allowing people to experience that, yes, they can, and giving people as many options as possible. And then once we've got that is then building in the consistency. So it'll often be some sort of like informal, contract sounds a bit formal, but some sort of guide and an agreement on what could be manageable for them in their current circumstances to do every day, and some sort of kind of recording for that. And then what I've tended to find is, some people really sort of quite like that and very sort of proudly come up and show me, look how much I've done in X, Y, Z. So just increasing people's options and positive reinforcement.
And I'm going back a question, but I guess one thing that I have found challenging is rolling with people's resistance at the beginning when they talk about, I failed so many times before, or I've either going back, like you say, to early experiences with PE, or just at other points in their life where they've tried to build an exercise routine. What do you say to people if they say, I'm just worried it's not going to work again, and then I'll feel even worse because I'll just be even further back than where I started?
So I would say to someone, what do you think you can do? If they're just could you manage 30-second walk? What do you think you can do? Can we just start there? And why don't we try? Let's just see, and I'll support you, and I'll walk with you, and I'll be with you as you have this first attempt. So that's kind of the thing I would do with someone.
And what are you thinking with building consistency at the point of discharge, or in the community, or I guess the trial work that you're doing now?
Yeah, so we I think a lot of the things that have worked well for people is much in line with what happens in the general population, is a sense of social support and cohesion for people. So we've done a previous study, walking intervention, where we had a walking group in a feasibility trial where we showed people can increase their physical activity levels with psychosis in the community, and that sort of sense of social support and meeting regularly at a set time every week and having a bit of social time was really important and reinforcing for people. So we're trying to replicate that within this larger trial that we're doing at the moment, where it's being co-designed for people with lived experience and carers and different types of professionals, so we can be adaptable to people's needs, but having some consistency to meet people in the community to try new things, and having a social element and trying to have a stable group is really important. So that's what we're trying to build on.
How has it been setting it up in the various locations, in the various trusts? When involving people with lived experience, involving carers, what kind of things do they say?
So it's been great. I mean, people are really keen to get involved. So if people are keen to get involved, I think my concern often with research or any initiative is what about the people who would perhaps even more benefit from this and aren't very forthcoming. So I think that's always something in the back of my mind. Are we getting the people who already have some buy-in, which is great, but what about the other people? So that's a consideration. And I think the sort of challenges which we've had with our feasibility study is some of the practical things, such as having a consistency in regular space. Sometimes we'll have like a meeting point within, I won't name trust, but one of the trusts, and then like the room needs to be used by another team or organisation or other event that has to sort of come in and do that. So I think some practical things have been an issue, and I think that it needs to be near public transport for people to be able to get access to. People can sort of find it, because when it sort of moves away from that, particularly outside of London, it becomes much more difficult for people to get access to. So it's been really valuable, and we're very hopeful that we'll have the intervention refined early part of next year, and we'll be testing second half of next year.
I'm excited to see how it goes. I wonder if I could bring us to think a little bit about what your senses of the different factors that might contribute to why movement does have such a link with our mental health, and why it could be so important. Both, and we've touched on this in parts in terms of also some of the improvements to people's physical health, which often co-links problems with that, often co-link with problems in their mental health. But I wonder if you could speak to the different things that may mean that movement can improve your mental health.
Yeah. So I mentioned the evidence showing the improvements in mental health, but I think we've had to have a great degree of humility to sort of kind of say that we really don't know anywhere near the full picture around why physical activity can improve people's mental health. And we really think it's very complex and multifactorial. And I'm not a person that believes, even though I have done trials looking at this, where we think it is due to BDNF release, for instance, or it is due to hippocampal neurogenesis. I think the reality is that many different factors and multi-systems, both within the mind and the body and society at large, play a role in why people have an impact on their mental health. So I think it's much more complex, and some of the sort of common ways which people have described it previously in terms of the improvements in mental health has been due to the runner's high and the release of endorphins has been one sort of commonly held belief. And when we think, and again I use the word think, is we think that it's probably not due to endorphin impacts, because endorphins, whilst they are released, they have difficulty crossing the blood-brain barrier and exerting their effect alone. So we think it's much more complex and multifactorial. We do see changes within activation within key areas of the brain. We've done trials in young people with sort of subthreshold mood disorders and shown that you see sort of stimulation in key areas in the hippocampus and the anterior cingulate cortex. We have also shown that you can get volumetric changes in key areas of the brain, such as changes in hippocampal volume too. So there's a number of different things which are going on a big level within the brain and sort of a connectivity viewpoint within the brain. So lots is going on. I think we don't know anywhere near as much as is to be revealed. And then in terms of the neurobiological factors, we do see BDNF increasing exponentially, this important brain fertilizer for stimulating neurogenesis and synapses between key areas of the brain. And then we see changes in some inflammatory markers which have been implicated and have been found to be raised in some mental disorders too. And other reward processing areas within the brain have also shown things. So I think there's lots happening, lots of theories, lots of noise, and we probably all contribute, and the extent to which they do is to be determined. And then outside of that there's lots of biopsychosocial, cultural factors which are going on for people too, and we can't negate those, and often more difficult to capture and measure. So changes in self-esteem, if I start to become more active and integrate in a walking group or a yoga group, then I will feel a sense of sort of social connection, and I'll feel a sense of, yes, I've achieved something. We can see changes in self-esteem. Then we get access to like green and blue space, and there's research by others at the Institute and other places showing that access to these type of spaces can have a positive impact on our mental health. And then we talked about other factors, other social factors too. So there's lots going on which are all contributing, and as I say, the extent to which they will individually contribute, I think, is to be determined.
So there's sort of these different levels of probably interacting and overlapping factors, and if we go back to the neurobiology a bit, So thinking about your hippocampus, which is an area that's important in emotional processing, it's the one part of the adult brain that's been shown that it can create new neurons. It's a part that's important in your memory formation. And it's also an area that we know that in response to stress and stress hormones, it can become smaller. And that's been shown to be potentially relevant in humans as well, as being an area that is smaller in people with depression and people with psychosis illnesses as well.
Yeah. It's an area reduced in psychotic illness also.
Okay.
And there's been some specific trials. It's not been consistently replicated, showing that you can get volumetric changes in hippocampus in response to exercise in psychosis.
Mm. And I guess my caution always with neuroimaging research or with things like that is we do make some assumptions. Like, we can't be sure that increasing the size of your hippocampus, or that showing in an animal, say, that there are new brain cells growing or new synapses, the connections between brain cells, these new connections being formed, we can't say for sure that these things are good, because they also happen with, for instance, it's been shown in animals with cocaine use that they grow new brain connections, that they grow new cells. But what I believe, and I hope you can say more about, is we have also shown the links between those things and some of the clinical benefits, some of the benefits in people's health. So we're not just looking at something that we see on a scan and leaving it there. It's gone further as well.
Yeah, so it has gone further. So often, if you're doing sort of the neuroimaging research as well, say for instance, in schizophrenia, is you will not just base your result off a volumetric change, but you will also measure things such as we talked about cognition earlier. So having a formal assessment of how people's problem solving may be, how people's attention may be. And what you tend to see is consistently is that you do see changes in hippocampal volume, but people who do see those changes have better, problem solving, short-term memory recall. So this goes to sort of bolster that, yes, this is not just, a small signal, but there may be some meaning behind it as well.
And it's linking both, I guess, the neurobiological and the psychosocial reasons for why movement may be good. I wonder if I could ask your thoughts on something. I mean, something that we've got interested in the podcast is about evolutionary psychiatry, and I guess the things that humans have been doing for a long time, or some of the reasons for why things may be important from the perspective of how we have developed as a species. And I guess up until relatively recently in human history, we were probably used to doing quite a lot of movement. Again, do you have any thoughts on how that links with your clinical work, with your research work, whether just how our bodies were designed and how our brains were, not designed, but how they arose, whether that's something to why we may need to bring in more movement to be healthier?
Yeah, so I think this is a real area of interest. So when we talk about how things have changed in terms of evolution, in terms of our body, and also psychiatry, is you're right in terms of the way that we lived our lives and the way we're required to move our bodies has changed substantially. Not only in terms of movement, in terms of what the tasks that we needed to do to go and get resources or find things that we needed in life has changed substantially, and be self-sufficient. That has changed substantially in terms of how we move our bodies, but also the concept of sedentary behavior has changed substantially over the last 20, 50 years. And we're aware about the physical health and some degree the mental health and cognitive issues around sedentary behavior. So what do I mean by that? We're all sitting a great deal more than we were 20 years ago, 30 years ago, 50 years ago, 100 years ago, often staring at screens, sometimes cognitively engaged, sometimes not cognitively engaged. So this has had a huge impact. So we've seen not only a change in how physically capable and active our bodies are, but also the other side of that coin is we're sitting much more and we're using our brains in a much different way when we are sitting. So I think there's some really interesting changes within that, and sedentary behaviour and excessive sitting. I'm a bit sceptical about the literature, although I have done research in this area, and one of the trials I'm working on is reducing sedentary behaviour. It's been associated with poorer physical health outcomes in the general population and worse cognition in the general population. So we are interested in this, and there's some interesting research which we and others have done looking at how the type of sedentary behaviour sitting during the waking day, how that may be differentially impacting our mental health. So we've done some cohort studies in Sweden and also in Brazil, showing that not necessarily all sitting is bad, but if we sort of subcategorize the reasons why we are sitting, then there may be a differential impact. So if what we've termed active sedentary behaviour or sitting, such as you and I talking now, we're both cognitively engaged and focused, and we're very much, our brains are working, does not appear to be associated with poorer mental health in the future. Whereas what we're terming passive sedentary behaviour, that could be, I don't know, staring, cognitively unengaged in a series on TV, or just not cognitively engaged, any of those different things. And that does tend to be associated with poor mental health. And I am using the words associations here. So I think that whole concept of our bodies are changing and what we can do, but then also when we're not using our bodies, that we're sitting much more, being sedentary, and this has an impact on our musculoskeletal body health, brain health. And I think the degree to which is to be determined, but it's huge changes.
And I've heard you talk about this before, and it just sounded really fascinating. So I wonder if I could ask you to briefly mention it today as well. But some of the interventional studies or experimental studies where they've made people be more sedentary, and I wonder what kind of sedentary they were making them be in that context, and the impact that had to also really give some nice evidence for their being, I guess, bolster up the evidence for this association.
Yeah, so you're right. So there's two trials, and there's been a few more since that I think are really quite pioneering in this. And whenever you do an intervention, is normally you want to do something which is going to be beneficial for people for ethical reasons and everything else. So asking people to be sedentary is a bit of a careful area to go on, bearing in mind the association literature. But anyway, some colleagues did this randomized control trial with 60 people in the US, and it was young people in their early 20s, free from any mental or physical health comorbidity, who were very active, so actively engaged in sport, and were doing 150 minutes per week. And the intervention randomized at baseline for 1 week was to be more sedentary and stop engaging in sport and exercise. For that group, and the other intervention, the other control group didn't, and they put accelerometers on people so they could see how much physical activity people were doing to account for that too. And what they saw in this group of people free from any symptoms is a spike in PHQ-9 score, as a measure of mental health, and particularly depressive symptoms score, which was significantly and clinically possibly important in this sedentary behaviour group versus the control group who carried on as usual. But then, thankfully, as soon as the intervention finished, they went right back down to the mean. So people's mental health went back to baseline. So that is a randomized control trial, and we like that type of study to understand things because it allows us to make causal inferences. Then there's another trial in the British Journal of Psychiatry, which did a similar thing. Again, people free from any mental or physical health comorbidity who are closely monitored. The intervention was being more sedentary, and the control group carried on as usual. They found a similar thing, that the highly active people who were asked to be sedentary and were monitored started to become more stressed and feel more anxious, and after a 2-week intervention. But there was also an inflammatory response that happened within this group. So some changes in some of the interleukin 6, compared to the control group and people's baseline. So there appears to be an inflammatory response as a result of this sedentary behaviour as well. And people did go back to the mean afterwards. And a wider body of research has shown that you do see inflammatory responses for people who are engaging in excessive sedentary behaviours over time.
And so this is something that I've long been curious about, and I don't know if it links with what you've said at all about this increase in inflammatory response with increased sedentary behaviour. So, we talk about exercise being good for aerobic exercise in particular, something that gets our heart pumping, and all of the benefits that you've discussed as being associated with that, with physical and mental health. But why do other things that get our hearts pumping, like being in a stressful meeting, or being stressed about paying your bills, or being stressed about anything at all that we also know kind of gets our heart rate up, why is that not linked with any kind of improvement? And sorry, I'm not asking why, expecting you to necessarily have an answer, but do you have any? Is that something that you've ever thought about, or do you have any thoughts about it?
Yeah, I have thought about. I mean, having your heart raised has a function, to prepare us in response to an activity or in anticipation of an activity, or a threat, if we use it in that term. So it's unsurprising. And I think when we're engaging in a stress to our body, then our heart is adapting to that stress, and we're experiencing benefits from the movement of our body, from the contraction of muscles, from the change in circulation. And that is probably why we see the benefits and changes in all the blood flow to the brain, etc. Whereas if we just, if we're experiencing a stressful event or stressful time, and we're sitting there, we don't have that physical outlet to allow the circulation to change and to allow the soothing nature from physical activity and exercise, then we don't tend to see the same benefits. In fact, that we know it's not very helpful for people to remain in that state for very long periods of time for a whole number of reasons. So probably, if I was going to guess, due to the physical movement aspect.
Yeah. So again, the contraction of muscles, and like you've talked about before, the improvement in muscle health, not just your heart and lung health. Brendon, I know we've done a whistle-stop tour of loads of things. I wonder if there are, I guess, some key either takeaways or anything that we've not touched on that would be really important, you think, for us to discuss in the time that we have left.
I'd just like to think key takeaways for me is hopefully we've been able to demonstrate that touch upon physical activity, exercise and movement. It can be really inclusive, and it should be really inclusive for people to engage in, and small amounts can make a meaningful difference to people. So whether you're working with patients or everyone, just relay that information. It doesn't need to be that you're doing 5 times 30 minutes a week and up to 150 minutes. We see greater benefits to people who are not very active, and just reinforcing that message, simple message that some is better than none and more is better than some. It's just a general good guiding principle for sort of people to engage within that, and creating movement opportunities for people. And I suppose I would like to sort of caveat this, and although we've talked a lot about the sort of benefits, and I think really the way that I think about this is it's really part of the menu of options, clearly, for the treatment of people's mental health and mental illness. I don't ever view it as a replacement for any other type of intervention, just part of a good holistic package of care that should be offered to people if they're interested and if they're able to benefit from it. So I don't want to come across as in this is being positioned as is superior or should be in the place of X, Y, Z. Absolutely not. It's just part of a treatment that can help some people at some times, like any other intervention. Not all interventions work for some people at all times.
And I guess you highlight that importance of choice and options, and that this is a very valuable option to offer to people, which can make a huge difference, but also that it does not have to be the 150 minutes that government guidelines suggest. Certainly not from the beginning. That's not the minimum over which you, unless you hit that, nothing happens. But that it's starting from zero and even building in 5 minutes and doing that every day or several times a week will give you a different feeling.
Absolutely. And the targets, which are labelled 150 minutes, they're meant to be aspirational targets that we should all work towards if we can. And the World Health Organization guidelines, which were updated a few years ago, recognise that some people, due to physical health, mental health, or a societal issue, may not be able to get there, and that's okay. It's not there. These are aspirational targets. They're not there for people to look at and think, oh, I can't do that, I'm never going to get started. That's not what they're designed for. It's not to say that there are not benefits for people building up towards that. And as we've discussed, people who are getting started tend to see the greatest benefits initially when going. So really great aspirational targets for people to work towards if they can. There's no race to get there. The key thing from the literature and behaviour change perspective is that initiation phase, which we've spoken about, and then really thereafter is about consistency in terms of engaging in some movement that you enjoy, and the intensity, how hard you're working, is less important. If you're training for an event, if you are doing that, you want to go or you're training for a time, then intensity is great for a short period of time working hard. But if you want consistency over time, then intensity is less important.
Okay. Brendon, thank you so much for your time. It's been wonderful to speak to you, and thank you for everything that you've shared.
Thank you for having me.
Thanks so much for listening this week. If you've got any feedback, as always, do get in touch. If you enjoyed the episode, why not give us a rating on Spotify or Apple Podcasts, because it really helps other people to find us. If you want to get in touch, you can find us on Instagram or Twitter, or you can drop us an email. And if you value the show more generally, why not buy us a coffee? Thanks so much.